I'm now going to open the floor for questions. Some of the questions are from last week as we felt they were more suited to our speakers this week. So the first question is for Dr. Buchanan. So this one is, any special advice or recommendation for type 1s going to go through IVF, particularly in relation to effects of IVF medication?
Thank you. No real special preparation for IVF other than everything we sort of mentioned in optimising your health in all the ways that you can. Usually when women are going through IVF or any assisted fertility, they will have a fertility specialist who is very well trained to look after women with diabetes, type 1 or type 2. And it's always in conjunction with an endocrinologist or obstetric medicine physician. So I'm not sure if I'm really answering the question, but I guess I want to give you reassurance in that going through assisted reproductive technologies doesn't grossly affect your glycemic control with the medications that are required. But I guess with everything, as Shelley touched on, is to be kind to yourself and to try and avoid stress as much as possible. Easy to say, I know. It's not just the IVF that can contribute to problems with diabetes, if that makes sense.
Thank you. I'm sure that did answer the question. The next one we have is for Dr. Shelley Wilkinson. So this one is, I find that I cannot achieve tight management of my blood sugars with the diet recommendations by dietitians during pregnancy, which is higher carbs than I usually eat. So I'm conflicted between following dietetic advice or the medical insistence to keep my management over my blood sugars. What is your advice?
That's a really tricky one, and I know when you're not pregnant, it's easier to go lower carb to keep the blood sugars in control. However, when you're pregnant and you're growing a baby, you're needing those nutrients as well, and a lot of the nutrients that come along with some of the carbs. So I would still recommend working with the team, so dietitian and your doctors, to work out the correct blood glucose for you, and there may be a need for management with medication if you need to be having more carbs to get the nutrients that you need to have a healthy baby. So it's quite individualised. It's hard to say go one or the other, but it's working with your team to work out what's the best for you to balance both the needs of a growing baby as well as to manage your blood glucose level, because the pregnancy is larger than just the diabetes.
Sure, absolutely. Thank you. The next question is for Stephanie. Hi, Stephanie. Did you go through public or private? Did you find you had good access to your multidisciplinary team, or did you have long wait times?
So I was, I guess when you're diabetic, you get pretty good care from hospitals, I found. But my obstetrician was private, but I was initially seeing the endocrinologist and educator were the public ones that I'd been seeing.
Cool.
So I saw them throughout.
Great. The next one is for Dr. Buchanan again. So this one's come up a few times in a few different ways. So we're just going to go with the first one. Do a high percentage of women with type 1 diabetes end up requiring a C-section?
I don't know the exact percentage, but I don't think any woman, I don't think a woman with type 1 or type 2 diabetes who has a cesarean section could always say that it's related to her diabetes. Having said that, any woman who has a large baby, and that's a woman who has type 1 or type 2 diabetes or not, is generally recommended to have a cesarean section. Whenever a woman is in labour, there's always a risk of an emergency caesar for, say, fetal distress or something that we call obstructed labour, where the labour just doesn't progress. And again, I don't think we could say that there was fetal distress because of your diabetes. Now, having said that, I guess if there was severe hypoglycemia, maybe, but I think, during a woman's labour, glucose, blood sugar level monitoring is so rigorous. It's unbelievable. So we would hope it would never get to that point. So no, not necessarily. I think if we looked at the statistics of cesarean section and worked out the percentage of women who had a cesarean section, we wouldn't say, oh, look, a high proportion of those cesarean sections were on women with diabetes. There's just so many other reasons for cesarean section, elective or emergency, to occur. Your diabetes, without a doubt, is, I guess, the number one overarching driver in a pregnancy and delivery. But there's just so many other things that can happen. There's just so many things that are kind of out of our control. Welcome to parenthood. That it's not just about the diabetes, even though it's super important. I hope that makes sense.
Yeah, absolutely. Thank you. The next one is for Dr. Wilkinson. So I am on a very low carb diet and it's working for me, but how low is too low for me? I would like a baby one day.
So again, the diet pre-pregnancy will differ from during pregnancy, and I know a lot of women are getting a lot of success with low carb or lower carb diets, and that's different for different people as well. But the guidelines recommend not going lower than 175 grams of carbohydrate in pregnancy. And if we're getting technical and we're looking at 15 grams being a serve, that's probably about 11 or so serves of carbs. And remembering that's not only breads and cereals, but fruit and dairy and starchy vegetables. So it might look, and also balancing out what you might need for pregnancy, that would be possibly 2 serves of fruit, 2 to 3 serves of dairy. It might be a starchy veg, and maybe we say breads and cereals, you need about 8.5 serves of breads and cereals or grains, but that might drop back a bit. We often do drop back a little bit with diabetes. That might still sound a lot, but that's quite a normal amount across the day. We would recommend good quality nutritious foods, smaller meals and snacks, and having those carbs as lower GI carbs to help keep blood glucose levels within range. I can't remember if I mentioned it in the talk, but often I do. 2/3 of thiamine come from breads and cereals and grains, so it can be quite a danger cutting out breads and cereals, because thiamine is B1 and we need that for a lot of body processes, including releasing energy from the food that we eat. So cutting out carbs, particularly breads and cereals, can be not particularly beneficial. Also, there's a lot of emerging evidence saying, and I'm focusing on breads and cereals because often that's the one that people cut out when they go low carb. Cutting out breads and cereals also cuts out that iodine and folic acid that the government are assuming that we're eating, and that's led the supplementation guidelines and how much they supplement in the food that we eat as well. So it's assumed that you're having some and then get some from supplements. But again, it's quite individualised, so working with your team to make sure that it meets your needs as well as the baby's needs, and you get good blood glucose control as well.
Great, thank you. The next one will go for Stephanie again. So this one is, what devices did you find beneficial in the lead up to your pregnancy planning?
Yeah, so definitely the insulin pump, because I'd previously been on injections, and I just found that helped me so much, not just with pregnancy, but I'm a runner as well, so just in terms of exercise. But definitely the CGM as well, continuous glucose monitor. So I'm using the Medtronic pump and CGM, and I don't know how I'd live without it now. It's just so good. And I guess just like having your educator or endocrinologist being able to look at the graphs and just seeing all the trends, it's definitely worth getting, and especially with the subsidy now when you're trying to fall pregnant or when you're pregnant, definitely worth looking into.
Cool. The next one that we have is actually kind of along similar lines. So I'm going to direct this one to Dr. Buchanan, and then if you want to ask Dr. Wilkinson to add in, feel free. So this one is, can you still wear your insulin pump during delivery?
Yes, you can. Yeah.
Cool. Okay.
Do you agree? Do you agree?
Yeah.
Fantastic. Okay, the next one, let's go again, Dr. Buchanan. So are there circumstances where a woman with type 1 could be supported to wait for spontaneous labour beyond 38 weeks?
Yes, but not that I would want to put words in other obstetricians or hospitals' mouths. But at the end of the day, I mean, can't make anyone do what they don't want to do. We can only just, inform you of what we perceive are the risks. And when we say the recommendation is this, it really is on a case-by-case basis. And so like as Steph said, she was getting ready for her induction of labour at around 37, 38 weeks. And there was something else that came up that she had absolutely no control of. So I guess what would be looked at is if glycemic control is good, if blood sugar level monitoring is still easy, if baby isn't growing too big or too small, then it would be a case-by-case discussion with the multidisciplinary team about what everyone's thoughts are on this. We could never say no at all. It would just still be on a case-by-case basis, and there might become a time in the pregnancy where, say, the obstetrician might start saying, or the endocrinologist might start saying, we strongly recommend this, rather than, oh, look, we loosely recommend it. So I guess the answer is yes. There could be a role for it, for sure.
Great, thank you. The next one for Dr. Wilkinson. Should I breastfeed my baby, and does diabetes affect my breast milk supply?
So I would, if possible, I would recommend breastfeeding. We do know that diabetes, particularly use of medication and insulin, can decrease what we call lactogenesis stage 2. And so that can be the letdown. So stage 1 is the secretory initiation, and stage 2 is secretory activation. So about day 4 is when milk's secreted and it changes in volume and composition. And so delays in that can delay success with breastfeeding. So what we recommend is around 36 weeks. There's a lot of studies around this now, around 36 weeks, engaging with the fantastic lactation consultants at the hospital. And you can do something called antenatal expressing. And so that basically gets everything going before baby even arrives. So when baby's arrived, you have milk, you have expressed some colostrum that you can actually give the baby if they have low blood sugar or they need something in birth suite, and your system's already going and ready and you're able to express. So it takes the stress off those initial first days if you know everything's already going, and there's been a lot of success with that now, and I know a lot of lactation consultants do that quite routinely with women who have diabetes in pregnancy.
Great.
Did you have anything more, Julie, that you wanted to add?
I can't, not really, except to say I can't recommend hand expressing colostrum enough.
Yeah.
I've never had.
It'd be a great skill. Like I wish I did that.
Actually, with all the women that I look after obstetrically, whether they have diabetes or not, I always recommend it. And everyone, not one person has said, I wish you did that. Everyone goes, oh, thank you so much. There's a lot more than just the milk production. It's just, and I could talk about this for ages, but it's just getting used to even thinking about breastfeeding, because we put so much effort into trying, and Steph, you'll probably agree, in trying to conceive, making sure we're healthy in our pregnancy, hoping our delivery goes okay, and then all of a sudden we're told, now you've got to feed this little one, and that can be super stressful.
Mm. Steph, did you have any experience with antenatal expressing?
No, well, I guess I didn't have a chance.
Oh, you didn't know? Yes, true.
When she was born, I had to express because she couldn't breastfeed straight away. So that's, so it would have been good to have some earlier. But, and I found it was challenging with my glucose levels. They were pretty stayed pretty low because of the breastfeeding.
Mm.
I was having a lot of hypos, but yeah, I'm still breastfeeding and glad that I am.
Well done.
That's great. That actually leads really nicely, Stephanie, into the next question, which did your diabetes management change much after having your baby?
Yeah, well, I mean, there was that. I had to worry about that. And then I guess because I was so focused on her, and sorry, she's crying in the background. Sorry if you hear her, but I mean, babies take a lot of your time. So I did find it hard to get back into good management. I didn't see an endocrinologist for maybe about 6 months after I gave birth, which isn't ideal. Isn't ideal, but so I would definitely recommend it's going to be hard, but you can have the CGM, the subsidy, for I think 3 months after you have the baby while you're breastfeeding. So if you can keep the CGM going, that definitely will help. Sorry to say it.
Yeah, no, that's good. Thank you. Next one for Dr. Buchanan. How is having type 2 diabetes in pregnancy different from gestational diabetes?
Most gestational diabetes is diagnosed at around 26 to 28 weeks after a woman does a glucose tolerance test, and that's recommended for all women. Sometimes gestational diabetes is diagnosed a little bit earlier if women have what we see are risk factors for having it, and they will usually either do, it's a little bit varied with different hospitals and healthcare providers, but they'll either do an early HbA1c or a glucose tolerance test after the first trimester when they can tolerate it. But other than that, once gestational diabetes is diagnosed, women are then essentially treated like they have diabetes. So from an obstetric point of view, not much difference, and the same sort of pregnancy care, recommendation for induction of labour, same sort of risks, particularly with preeclampsia and large for gestational age babies or small. And generally, once a woman has gestational diabetes, once they have delivered, which is different to someone with type 2 diabetes, is that we essentially say from the minute of delivery, you can now eat what you want. You don't have to, you don't take your insulin or your metformin or whatever. Act as normal, be as normal, and then repeat your glucose tolerance test at 6 weeks postpartum. So that's essentially the main difference. A woman who has type 2 diabetes has a woman with gestational diabetes has an increased risk of gestational diabetes later in life as well. Is there anything else you can add, Shelley?
Just one thing that came to mind then was the treatment targets would differ pre and post. So maybe if you have type 2 diabetes before pregnancy, they'd get tighter during pregnancy, probably to the similar that we would recommend for gestational diabetes. Yeah. But those treatment targets would be for the same for if you had type 1 diabetes as well, wouldn't they? Yeah.
Great. Thank you, guys. The next one is for Dr. Wilkinson. So what are the dangers of drinking caffeine, so tea or coffee, during pregnancy?
It depends on how much you drink. So we recommend no more than one sort of coffee shop coffee a day, but you can have up to 3 coffees or teas a day. The studies that were done in pregnancy were actually done when they took caffeine in liquid form and then they dried it down and separated it and then fed it to rats, which then they lost their pregnancies. But the amounts that they gave to rats at that time were far, far, far above what we would be even able to drink in a day if we were really going hard every single day. So I'd say just drink sensibly and don't have too many espressos, but a couple of coffees or teas a day is okay. And they're probably better to have than a soft drink with caffeine or an energy drink. Yeah.
Sure.
And do you mind if I just add in there as well, most women in the first trimester really don't feel like coffee.
Yes, that's right.
Remember that, Steph? And sometimes it's the almost the way that women know that they're pregnant, because all of a sudden...
Yeah, I definitely found that.
Yeah. So, and after the first trimester, generally women might venture out and have tea or coffee, but should we even be drinking more than that amount anyway, Shelley?
That's right. So probably not, no.
Well, I'm sure the coffee and tea drinkers will be happy to hear they are still allowed to have some.
And there's so many, like coffee never comes out bad in any study anywhere. Like coffee's actually, and tea as well, you've got the antioxidants, it actually does good things all round. So 3 cheers for coffee.
Oh, that's great. Okay, this is actually our last question for Stephanie. So who was part of your support team and how did they assist you? So that's not only, I guess, your support team medically, but who else kind of played a role in the support process?
Yeah, definitely my husband, Jeff, and my family. And then I've got some friends who are type 1 diabetic and they'd been through pregnancies before. So that was good talking to them and asking them lots of questions. Definitely family.
Right.
I'd like to add something in there quickly as well. Support team during delivery. So for a vaginal delivery, most hospitals will allow, coronavirus has changed things a little bit, but in general, for a vaginal delivery in the birthing suite, most women can have, 2 support people for a vaginal delivery. For a cesarean section, there's usually only 1 support person in the operating theatre at the same time. As you can imagine, you can't have too many people in that space. It needs to be quite sterile. So practically, and I don't know, was your husband with you during the Caesar?
Yeah, just him. Yeah.
Well, it's definitely good to have that support person there then, I'm sure.
Yeah, I was really surprised surprised how many other people were in there, all the doctors and nurses, like it was amazing.
Yeah, we always have to, always need to reassure the women, everyone has a job here, they're not sick. Yeah. Everyone has an important role here in the operating theatre. In the birthing suite, it's much more quiet.
Good to know. Well, thank you, everybody. Amazing that you could be here with us tonight. That's actually all we have time for, but we really appreciate your time and we hope that everybody has enjoyed being able to ask all those questions. Right. So if you missed out on getting your question answered, please call the NDSS helpline on 1-800-637-700 to talk to a health professional. They would be more than happy to help you. Please be aware that the advice provided in this presentation is general in nature. Please consult your health professional care team for advice pertaining to your personal history.